Thanks, Richard. And Richard, I'd like to echo your comments and welcome everyone to what I think and hope will be a really great afternoon and an enjoyable one. And we will all benefit from it. So my objective is to set the tone, if you like, for the rest of the day by reviewing some aspects of where we are now in terms of nutritional status of Canadians. In terms of disclosures, there's nothing which I'm going to tell to you which has got any drug-related or commercial bent, so I'm not worried about that. If I was going to make any disclosure to you, it would be with one of my favourite introductions, which is that I'm a classic case of the poacher turned gamekeeper. And for those of you who watch Downton Abbey, you'll know what that means. I spend my life doing colonoscopy and diagnosing cancers and seeing people with fatty-related liver disease. And I was content with that for the longest of time. But as you get a little bit longer in your career, you say, hang on a minute, I mean, maybe it would be more reasonable to try and prevent some of these problems as opposed to try and fix them once they've developed. So later in my life, I've become much more interested in nutrition, and there's no question but that if we're going to move forward and reduce the burden of illness that the system has to bear, that we've got to take this on board. So specifically what I'm going to cover with you are the demographics of our population in all of its diversity, the challenges which we have, the role which nutrition might play in Canadian health, and some suggestions for how we might move forward. So here's the population, the last census, 2011, and it's shown from 0 to 3,000, and that's on the left axis against age across the bottom axis. And you can see it's fairly evenly distributed up to about the age of 59 or so. Then you can see the boomers just preceding that, and then as people age, it begins to fall off, as inevitably it does. Now, unquestionably, the impact on the healthcare services is age-related. It's most intense in early childhood and as you get older. And that data is well known. So that little baby boomer bump that you can see from age 49 on is going to have a very profound effect on our healthcare system utilization and resources and access to care. And we need to plan for that. And one of the things that we can do is try and reduce the burden of illnesses which that population has. And there are preventative strategies, but without question, nutrition is one which has the potential to have a huge impact. The Canadian population is quite diverse, and you may have seen this. Statistics Canada released this on September 19th last month. So there are now 9.4 million census families. Lone parent families have risen 8% to 1.5 million. Male lone parent families have increased by 16%. Female lone parent families increased by 6%. And young adults, 40% of them live at home. So what does that mean for the discussion we're having today and for you as an audience? It means that delivering nutrition, healthy nutrition, to these populations has some peculiar challenges. It's not exactly the same thing if you're cooking for a family than if you're cooking for yourself or perhaps one other at home. In terms of seniors, 92% live in private households, 56% as part of couples, 25% of seniors now are living alone, so have lived alone, 11% with relatives, 8% are in nursing home, and women over 65 are twice as likely to live alone. So what we've got then is a very dynamic matrix. If you look at it, we have nutritional needs which are specific to childhood and to teens and to young adults and to middle and to seniors on one side. And then you've got all these other factors which are impacting it. Gender, economic situation, geography, marital status, education, culture, personal preferences, and throw in the incredible complexity of perhaps having one or more diseases. So it becomes extremely complex in terms of getting a message out there for what is healthy eating for this very diverse population. It's living in a number of different circumstances, and it has many other influences which influence food choice. In terms of how we're doing, well, it could be worse, but we certainly have our challenges. And this is from the Canadian Community Health Survey, 2011. And what it's showing is the self-reported by age group and sex percentage who are overweight or obese. And you can see that this starts pretty early on. So the 18 to 19-year-old group, over 20% are in that category, and it rises fairly steadily up to about 65. So that by age 45 to 64, almost 70% of males are overweight or obese, and a smaller number, about 50% of females. And of course, those obesity-related diseases drive an incredible amount of healthcare utilization. Hypertension, diabetes, kidney disease, hip replacements, on it goes, is driven, at least in part, by obesity and being overweight. As the weight goes up, as you might figure out, physical activity during leisure time in Canada goes down. It tends to be highest in the teen groups, and drops steadily as people get older. So that by age 65 and older, even by liberal measures, only about 50% of people are participating in some form of meaning physical activity during leisure time. And this is one of the slides which I like to show to our medical students. And without fail, not one of them ever knew this before, which is kind of amazing. And what it shows is caloric requirement on the left against age across the bottom axis. The spread of the bars is for people with low activity versus high activity. So at the upper end of one of those red bars would be people who are moderately active. And what the shock that comes for all of my medical students is that I tell them metabolically, by age 19, you're done. You're over the hill. And your basal metabolic rate from age 19 on starts to drop. And it's not anything that you've done or not done, it's just the way it is. And the implication of that is that if you continue to eat the same way and exercise the same way as you did at age 19, you will inevitably gain weight. We are programmed to get heavy as we get older because our basal metabolic rate, which accounts for about 2/3 of all of our energy requirements, drops steadily with age. So we're getting obese or overweight to some extent is kind of built into us. And we're going to have to actively overcome that if we want to prevent it. Not surprisingly then, the body mass index of overweight or report, this is youth by sex, is high. And if this is our starting point, and it gets worse with age, of course we end up with 70% of people overweight or obese by age 70. And with that weight issue comes the diseases. This is diabetes by age group and sex, 2011. Relatively uncommon in the 12 to 19-year-olds, but in one form or another, by age 65 and over, diabetes affects 1 in 5 Canadians, which is a startling number. High blood pressure, of course, follows the same pattern, uncommon in younger years, but rising to almost 50% of people over the age of 65. Fruit and vegetable consumption is exactly as you might imagine it is. This is 5 or more helpings per day by age group and sex. About 40% of people would meet that in the teens and somewhat lower at age 65. But that means that 60% of people, at least, are not meeting Health Canada's requirements as outlined in the Healthy Food Guide. Contact with the doctor is fairly steady throughout all ages, but of course becomes more intense and more complex as you get older. So to conclude, I think our mission, the CDHF, the reason behind this conference today is that we think we're in the business of promoting optimal health and optimal longevity and quality of life with the least impact on the health service. I mean, that's what we want to do. And I suspect that many of you in the room who are nurses or nutritionists or other healthcare providers would also like to meet those goals. How are we going to do it? Well, traditionally the way we do it is we fix problems when they arise, but we've got to recognize how incredibly powerful nutrients are. And I'll give you one example, which is neural tube defects. Common problem occurs around day 28 in the embryo, and you will have seen kids who have had spina bifida, or you've perhaps got a sibling with it. This is a paper published in the New England Journal in 1993. An expert panel of healthcare providers met and recommended folate supplementation for women who may become pregnant. You can see from 1993 to 1997 the impact of that recommendation: nothing. So healthcare providers are always making these guidelines and recommendations, and the public completely ignores it. That's the way it is. But then in 1998, the Americans said, we're not buying any more Canadian wheat unless you add 100 micrograms of flour, 100 micrograms of folate to a kilo of flour. And look what happened then: a 50% reduction in neural tube defects almost immediately. So these nutrients and micronutrients are incredibly powerful, and they're at least as powerful as many of the drugs which we prescribe. The challenges are significant for sure, but as Richard said, I do have the pleasure of working in a few different countries, and I can tell you that there are a few countries that have the wealth and resources that Canada has. If we can't solve this problem and tackle it, there's no hope for anywhere else. We have incredible wealth. We have very high-quality healthcare. We have academic institutions which are the envy of the world. The Canadian healthcare system has the right ethical values around equity and fairness and justice, and we have committed people, as evidenced by the fact that you're here. What we haven't done is meet the challenge and work together as well as we can. And on that positive note, because I do think it is a positive thing, and I hope that today is the start of something new, I'll conclude, and I think perhaps we have time for one or two questions. Thank you very much for your attention. Any questions? Or are you too shy yet? That's okay. We'll have, after the break at 3, we're going to have a chance as well.